Thanks for that intro, Maxime. Very nice. I need to get a recording of that. I think if I were to tell my family or my kids that, they seem to be not that interested. So I'm just going to have to play that back to me and myself sometime. But yeah, thanks for having me here today. A lot of really inspiring talks thus far, and it's just a phenomenal opportunity. Just to go through a couple of disclosures, I don't have any personal financial relationships with any vendor, but my work, as Maxime alluded to, is supported through the NIH as well as the Department of Defense, paid to the University of Michigan. And so what I wanted to do today, and I'll probably jump through some of this early content pretty quickly because it's probably the most advanced audience I've given this talk to. Some of you guys are probably further along than me on some of these topics, but just want to provide some background and context to where we are today, like what got us here, and some of the terminology around machine learning and AI that gets maybe thrown around a little bit haphazardly. So I just want to set the stage for just kind of a baseline about what we'll be talking about today. And then after this, I want to quickly transition to more interesting things that I think are best illustrated through going through examples of either current or near future examples of machine learning and AI that anesthesiologists might conceivably use. And for each example, I'm not going to go into the full details of each of these studies, but I suggest for those that are interested going into those details, they can just read about these studies. But instead, I want to use the two examples that I have the time to discuss today as a way to illustrate a few critically important dilemmas in machine learning applied to healthcare that we've already heard a lot about today, and that all clinicians should become acquainted with. And so by the end of this talk, I hope that I've brought to the forefront some of the ways that we can apply machine learning derived inferences appropriately and mitigate against some of the logistical, social, and ethical dilemmas that they will bring in, which we'll also cover in other parts of this panel. So just really quick, some background and context. It's helpful to kind of talk through the different types of AI, just so we're all on the same page. It can be illustrated in 4 different levels. There's type 1, the first type of AI is called reactive AI. This has been around for a long time. These are AI systems that have no memory. They're task specific. An example of this is Deep Blue, the IBM chess program that was able to beat Garry Kasparov in the 1990s. We're long since past this type. Type 2 is limited memory, and these are AI systems that have memory, so they can be used, they can build upon past experiences to inform future decisions. Some of the decision making in Google self-driving cars are designed in this way. And there's several really important weaknesses and vulnerabilities here, which we'll highlight in this talk. The third type is theory of mind. It's a psychology term. And when applied to AI, it means that a system would have the social intelligence to understand emotions. So we heard in Lee Fleischer's talk that quote about how humans have godlike technology, but medieval emotions or primordial emotions. I think it does ring true, and it's a challenge that we have with human factors engineering and kind of the human-machine interfaces. And then lastly, there's this level called self-awareness, where AI systems actually have a sense of self, which gives them consciousness, and machine, with self-awareness can understand their own current state. They have, the ability to bypass our own intelligence. And so to be clear, where we're at today is this second stage. The other stages are still, far off in the future, but I'd like to just talk about the limited memory stage, which is really just kind of the tip of the iceberg when we're applying it to healthcare. That's what we're going to be talking about today. What's the goal? You guys have seen this type of slide before, I'm sure, but it's helpful to reiterate that physicians will always have a place in medicine. Machine learning algorithms are great tools, but no substitute for the judgment, intuition, and care of a thoughtful clinician who understands the full impact of our clinical decision makings through experiences taking care of tens of thousands of patients in their lifetime. There's strengths and weaknesses to both humans and machine learners. Again, I'm preaching to the choir a little bit with this audience, but with machine learning, The advantages are that you can make rapid and accurate and quote-unquote unbiased decisions, but I put that in quotes because if algorithms are trained on clinical decisions made by humans who have biases, it will learn those biases and reflect those back at us. So we have to be aware of that. The downside is that there's often a lack of transparency or understanding exactly how the algorithm arrived at either a treatment recommendation or a diagnosis or whatever it's being used for in the healthcare setting. There's also this lack of understanding of the downstream consequences of the decision. And so that's where humans are very important. We understand the implications of our clinical decision-making through experiences taking care of, again, tens of thousands of patients in our lifetime. But we are very expensive and we are slow to process information on the scale when compared to machine learning algorithms. Why do we care? Again, I'm preaching to the choir, but changes induced by machine learning and AI, they're disrupting every industry, and healthcare is certainly no different. And we all know that these changes are coming, and some of them are already here. The best thing we can do is prepare for them. And just like interpreting or trusting or applying studies in anesthesiology or any other published clinical journal, it demands the reader to have a basic literacy in statistics and study design, interpreting, trusting, and applying technologies using AI and machine learning derived inferences. They demand a literacy in machine learning methods. So that's kind of my motivation to a clinical audience for why we should care. Finally, why is it so hard in healthcare? These are just reasons that I'm sure we've heard before, but one of the most important is that mistakes really matter. So if Facebook were to misclassify your face as your twin brothers, that's annoying, but it's not really dangerous. Contrast that to a prediction about the diagnosis of sepsis or a patient deteriorating. That can be much more catastrophic if the wrong inference is made. Also, our culture is just less tolerant of errors made by computers. So a self-driving car wouldn't just have to be better than a person to be accepted. It'd have to be nearly perfect. Another issue is that being right isn't enough in healthcare. It's not just about getting to the right answer. We need to actually understand the mechanisms of our answer and be justified in our clinical decision-making so that we can mitigate and anticipate and mitigate against the next problem that a patient will have for which we may not have an algorithm to support our decision-making. And then finally, there's just limitations to data sharing. We've heard a ton about this interoperability issue this morning. And there's certainly the PHI and data sharing issues. And there's also simply even if we were able to overcome those, there's also the issues of proprietary nature of some of these algorithms being used. So with that overview, we can jump into two, I think, deeper examples of studies that have been published using machine learning and AI-based algorithms and use those, again, as a substrate to talk about logistical, social, ethical dilemmas in the implementation of these algorithms. And so first thing I'm going to talk about is a study published in ATS validating a deterioration index model among hospitalized patients with COVID-19 admitted to the hospital in an inpatient setting. And the goal of this study was to detect before a patient deteriorates, defined as being transferred to the ICU, being intubated, mechanically ventilated, or dying. So trying to predict deterioration of a patient with COVID-19 admitted to the hospital. A cohort was at a single academic medical center, admitted to a non-ICU setting. And the data collected was basically what is routinely collected on most hospital inpatients. Didn't try to extend beyond that. So just staying with what's routinely collected within a EHR as a starting point. The goal was to produce a score 0 to 100, representing the likelihood of deterioration. And the algorithm performance was average. It wasn't amazing. It's not a worthless algorithm, but also far from perfect. And for those who are interested, I direct you to reading more about the performance and the limitations here. You can read the study. But what I want to talk about with my time here today were some more deeper questions about this algorithm. How does it work? why should we trust it or not trust it, and in what clinical context would it be more or less effective, and then also what should we do with this information. And as it turns out, there's multiple considerations for a model to be trustworthy and useful to clinicians on the front line. At a minimum, the model has to be accurate, but that's only a starting point. There's many different layers to address for a model to be, again, trustworthy and useful to clinicians. So building up from this base layer of accuracy, we've heard this before, but that needs to be transparent. So a clinician needs to understand what factors are driving a prediction model, not just the end result. And in this situation, mechanisms are very important. So just like the many causes of hypotension will imply different treatments, the same is true for a prediction model. Is it the patient's arterial lactate of 4.5 that's driving the prediction, or is it the patient's respiratory rate of 6? Beyond this, models need to be credible. And that is to say, does the variable that's driving the prediction fall in line with subject matter expert opinion, or is it in contrast to decades of literature on a particular topic? And that's not to say that experts can be wrong, they can be, but it's uncommon. And so for a model to be credible, it needs to be influenced by variables that have plausible biologic mechanisms underpinning the relationship. For example, if a model was influenced, if this deterioration model was influenced by the patient's age and vital signs and a blood gas value, that's potentially more credible to a critical care physician than a model that seemed to be driven by perhaps maybe the day of the week or the patient's height, serum chloride level. And that's not to say that that useful predictions can't be made on those variables. It's just to say that there are variables that experts hold in higher regard and will carry more weight than other factors. So if it falls in line with factors that an intensivist has come to trust through decades of established research, review of the literature, and care of the tens of thousands of patients coming through ICUs, again, that has a more credible, that's a more credible model. And then finally, at the pinnacle of all this is that a prediction model needs to be actionable, or at least informed by modifiable risk factors. So it's one thing to have a prediction model for deterioration that's influenced by age, comorbidities, patient sex. But when it's another thing when it's built upon variables that can be modified in real time, such as the blood pressure, the pulse ox, the hematocrit. And when you have variables that are plausibly tied to interventions, again, you're still having to grapple with this association versus causation issue. But if they're at least plausibly tied to interventions, then there's at least the potential to inform clinical decisions beyond just risk stratifying patients. So taking into account these principles of transparency, credibility, actionability, here's how the EPIC deterioration index, and I have no financial interest in the EPIC deterioration index. This is a slide that's publicly available, but it's a good example of how I guess healthcare prediction modeling is starting to think about these principles of transparency, credibility, and actionability. I just want to show again how this might work, and how information might be displayed to clinicians in a way that's more useful. So not only do patients get a probability of a patient, again, deteriorating, defined as going to the ICU, being intubated or dying, but they get transparency into what characteristics are driving this machine learning model. So it's really the patient's age, the respiratory rate, and the fact that we can't get a neuro exam on this patient. That really seems to be under the hood driving this prediction right here. We get some credibility in understanding how important these variables are to the model. And then finally, it embraces actionability by incorporating at least a few potentially modifiable risk factors. Now, this isn't a panacea, but by showing what's under the hood, this deterioration index is much closer to earning a clinician's trust than displaying a seemingly magical black box risk score on the left. So I think it's a start. It's not, again, there's many more problems to be solved, but I think this is, again, a large step towards useful information being presented to clinicians. Another dilemma to address here is this issue of data set shift. So to make a model trustworthy in healthcare, we need to take on this issue, which is broadly defined as an evolving mismatch between data that an algorithm is trained on versus tested on, which can lead to the underperformance of a machine learning algorithm. I bring this up because there's a lot of prediction indices, such as the epic deterioration index, that were found to have a precipitous drop in performance when we had the black swan event of the COVID-19 pandemic, where patients admitted to the ICU were dramatically different. We had a completely different kind of demographics or set of profile of patients admitted to the ICU in 2020 than we had the year before. So there's this issue of data set shift that a lot of hospitals are now taking on and thinking about. And although the COVID-19 pandemic is a stark example, this issue of data set shift is happening in much more subtle ways all the time. It can happen, again, when the patient demographics or comorbidities of a patient population going to a healthcare system changes. But it can also happen when there's some fundamental change in the healthcare delivery system. So if you're switching software vendors in the healthcare system, again, there's this issue of interoperability, and we may have underperformance of an algorithm simply due to the changes in how the data are entered. The changing definition of a disease. So if the definition of sepsis or the definition of hypertension changes as defined by consensus guidelines and on a panel of experts or society, that will influence the performance of a prediction model. There can be changes to clinician incentives. So the billing for a heart failure exacerbation, the billing for that admission becomes is doubled. There might be a new incentive to document this more frequently in the medical record than there was the year before. And so all of these things happen in subtle ways and can really erode clinician trust and usefulness of these algorithms. And this has led a lot of hospitals to start thinking about developing healthcare algorithm governance committees, which can actually kind of monitor and turn on and off algorithms deployed in a clinical setting based on both kind of a command center broad level overview of the algorithm's performance and also just observations from frontline clinicians who might say, hey, this algorithm that seemed to be working well last month, it's not working well at all right now. Something's going on. And so different hospitals have been thinking about doing this. It's not just how good the performance of an algorithm is at the start. It's about how do we maintain these algorithms? How do we govern them? How do we ensure that we're doing less harm than good? And so U of M, just like some other medical academic medical centers, has developed what's called the Clinical Intelligence Committee, where we have worked on developing ways to monitor algorithms that are embedded into the EHR and making sure their performance doesn't dramatically change over time. The key to having an effective algorithm governance team work is to keep that communication between the frontline clinician and the governance committee very tight and rapid, and needs to be a very multidisciplinary committee. Both clinicians, informaticians, ethicists need to have the ability to communicate very quickly with each other. And so there's a QR code for a New England Journal of Medicine viewpoint on this issue that I have on this slide for those that are interested in learning more. Second example I want to talk about today is now a study that's been published 5 years ago, but I think it has an interesting point that I want to illustrate. It was a study published in Anesthesiology looking at the prediction of post-induction hypotension. And the goal of this algorithm was to use data available in the EHR prior to induction to predict the likelihood of post-induction hypotension. It used a single center data set of older children and adult patients, and again, used data that was commonly available in the EHR, both in the anesthesia H&P and in other sources within their EHR, including baseline blood pressure prior to induction too. And what we found in this study was that in a test data set, the best performing prediction model, again, just yielded modest performance for predicting hypotension using data available prior to induction. Again, not perfect, not worthless, somewhere in the middle. And again, if you're interested in learning more about this algorithm, I direct you to the study. But with my time here today, I want to talk about what would we do with this information to make it useful and actionable? And the answer to this is, like so many things in healthcare, it depends. It depends on the nuanced clinical context, and it also depends on the shared values of the anesthesiologist and the patient, which we can call judgment for the purposes of machine learning modeling. And so in this slide, I just show kind of the anatomy of a clinical decision being made, or really any decision being made. And we can start with data that is used by a machine learning algorithm to make a prediction, which is simply what a clinician needs to know in order to understand what will happen next. And then there's this other component that gets much less attention, which is judgment. And that's the values used by a clinician or algorithm to value different outcomes. So this is basically what a clinician needs to know in order to take action. And I want to just walk through a hypothetical example of how this algorithm published might be used and some of the dilemmas that we have to confront as clinicians if we're really going to make this useful. So to illustrate this concept of clinical judgment, I want to work through a hypothetical example. This is a 74-year-old gentleman who is relatively unhealthy, severe carotid stenosis, COPD, renal insufficiency. They're getting a major surgery. And let's just say we plugged that data into our post-induction hypotension prediction algorithm. We find that the probability of post-induction hypotension is 98%. And in this example, let's just assume that the algorithm has basically perfect accuracy, because there's still some huge limitations to the algorithm, even in this case, which are important to consider. If we believe that hypotension is bad, which we may or may not, but let's just say hypothetically we believe that, and we want to do something in order to mitigate the effects of hypotension. And so for the sake of argument, let's just say this ASA4 patient with carotid stenosis is at a 1% chance of having a stroke if we do nothing. And they're at a 10% chance of having a pulmonary complication related to their COPD after the surgery. And they're also at a 10% chance of having acute kidney injury based on their baseline impaired renal function. So if we argue that the risk of a stroke or any of the other complications is unacceptably high, we can take action. One action we could do in this simplified hypothetical example is we can give the patient a fluid bolus, and that will raise their blood pressure, which is at the detriment of more fluid in the lungs and maybe increases the risk of a pulmonary complication, but it's at the benefit of the kidneys, which have improved renal perfusion, maybe a reduced risk of AKI. We also have a third option. We can give patients some phenylephrine or some norepi, and in this hypothetical example, let's just say that it's equally effective for mitigating the risk of a stroke. It cuts it in half. And it doesn't pour fluid into the lungs, so maybe we have a similar risk of a pulmonary complication. We don't have an increased risk of a pulmonary complication. But it does clamp down on the renal vasculature. And again, in this hypothetical example, let's just say it leads to an increased risk of acute kidney injury. So where am I going with all of this? We have three choices, three consequences, clear trade-offs. And if we recognize that not all complications are equal, that is, having a stroke is way worse than having a pulmonary complication or acute kidney injury, then we need to make a judgment call. And we can't just, if we were just being purely quantitative, we can't just add up these percentages. It's not enough to know that a stroke is worse. We need to know exactly how much worse a stroke is than a pulmonary complication or acute kidney injury. And so I'll pause here for just a few seconds, and I'll let you ask yourself, how many acute kidney injuries or pulmonary complications would you be willing to tolerate in order to avoid one stroke? Is that 10, 100, 1,000, 10,000? An infinite number of pulmonary complications or acute kidney injury? Let you decide. It's an interesting thought experiment. So these judgments are things that we as clinicians do intuitively all the time, but we rarely explicitly codify these into relative values, which is fine. We can rely on our experience and training to have a sense of what's important. But if we're really going to be precise about minimizing harm to this patient, at some point we do need to decide exactly how much worse a stroke is than acute kidney injury or pulmonary complication. And so This is actually, when we do this, this is actually a machine learning technique called reinforcement learning, where we reinforce our decisions with good outcomes. We penalize our decision-making by bad outcomes. And we adopt a policy, which makes a judgment call about the relative burden of each bad outcome, and then decides on the outcome, the values, and then it will make a decision that minimizes the total overall burden. And so I recognize this in this hypothetical example. Let's just say that a stroke is 50 times worse than a pulmonary complication, 100 times worse than acute kidney injury, and that's totally debatable. And I actually encourage this debate because I don't think we often have it. But let's just say in this example, these are the values representing our judgment as a clinician. At this point, you can actually do some math. Now, it just becomes an expected value problem where we multiply the burden of each outcome by the probability it'll happen, assuming that these are the entire universe of complications. I recognize that's a vast oversimplification, but let's just say in this hypothetical example, these are the three things that we're worried about. And so what we find out is we can do this, and we can figure out that giving a vasopressor is the best choice among these three courses of action for this patient. And so we give some phenylephrine. Maybe the patient has acute kidney injury after the surgery, but wakes up neuro intact. And so taking a step back here, the really interesting part about this whole problem was not the probability of the hypotension, nor was it the probability of any of these complications happening, but rather it was the unspoken judgment, the clinician's intuition about the relative harms of each complication that was at the core of the clinical decision-making. So how do we get at this? So forgetting machine learning for a second, should we be having these kinds of conversations? Who should be involved? Should it be hospital, other clinicians? Should the patient be involved? So I just want to jump back to our decision kind of anatomy slide. We're making great progress with analyzing data to make predictions, but there's much progress to be made looking at quantifying judgments for clinical decision-making policies. The stroke versus the pulmonary complication versus the AKI in this, again, overly simplistic hypothetical example. But that's really where we need to make progress if we're going to be implementing these types of algorithms. How to kind of figure out this judgment, this intuitive judgment that we have as clinicians caring for tens of thousands of patients over our career. It's really, I don't have a great answer for how to get at this issue, but it is an interesting thought problem. And what I can say is that whereas we can't explicitly quantify our own judgments, that might be okay. We can actually use an algorithm to reverse engineer and learn our judgment by predicting our actions rather than predicting our outcomes. So an algorithm learns our value system based on what decisions we make in a variety of situations. Of course, there's a huge caveat to this, which is that it will propagate our own biases if we're not careful. If an algorithm learns our own value system, we need to be careful about what biases we already have that influence those values. And so here's oops, I'm just gonna go back. I guess there's this more high-profile example of bias creeping into a prediction algorithm. There was a example where Amazon would try to predict whether a candidate applying for a position at Amazon would be a successful hire, and they developed an algorithm that looked at resumes and predicted whether or not this patient would be a successful hire based on previous hires. It learned that this algorithm actually, when they dug deeper, they found that there was a bias against females. If you had anything in your resume that revealed that you were female, it would deprioritize your score of your probability of being successfully hired. And so this algorithm was scrapped. It was absolutely flawed, and I think there's some learning to be done here, but it is an interesting example of how bias can creep into algorithms and have potentially catastrophic consequences. And it gives us an opportunity to reflect about how we need to mitigate against more subtle biases than a sex bias. Obviously, this is an important example, but there's much more subtle examples too in healthcare where this is happening, and we need to think about how we're going to monitor and mitigate against those issues. Just some take-home points. I think machine learning is conceptually feasible, and we can certainly take studies and embed machine learning algorithms in the electronic health record. But it's really the maintaining of those algorithms, making sure they're generalizable, safe, unbiased, clinically actionable. Those are really the challenges that we have, and that we've heard a lot of already really outstanding talks today about. What can we do today? I think some of the next steps are for us as kind of thought leaders in this area to make our colleagues aware of the limitations of AI and machine learning, use it to improve care and not to incentivize misguided practices. That's a huge issue. We need to know what are the right problems to solve. So usually these are lower risk issues. So we may not be wanting to necessarily focus on predicting sepsis or clinical deterioration, but maybe we want to just figure out a way to optimize our outpatient clinic schedule or at our pain clinic based on the weather patterns or based on the day of the week or based on the patient's complexity. That might be a lower risk problem to solve, where maybe the data for making that prediction is available and it's not subject to outliers or nuanced clinical contexts. We need to understand the inputs coming in. So if we all know the saying garbage in, garbage out, but if your data is irrelevant, inaccurate, or biased, even the most sophisticated algorithm won't be able to work. We need to seek transparency, actionability of these algorithms. So just like we need to know how a pulse ox works in order to understand whether we can trust and act on a low SpO2, we need to also understand how a machine learning model works in order to understand whether a prediction model can be trusted and whether acting on it would even make a difference at all. And finally, we need to encourage our clinician colleagues to learn our biases before an algorithm mimicking our behavior makes decisions potentially reflecting our own unconscious biases. So with that, I thank you, and I'll be looking forward to other panelist talks, and we'll be answering questions at the end of this panel.
Thank you.